Hi, welcome back. This is the last topic for Delirium, which is management of delirium. Let's start. So in delirium management list, there are a few things that we have to consider. Knowledge and addressing the underlying cause is very, very important in delirium. Be mindful of the environment to minimize distractions, decrease noise, glasses, hearing aids, put them in. Sleep assessment is very important. Lack of sleep affects circadian rhythm and predisposes to delirium. Hence, earplug, eye mask, melatonin are very important. Melatonin is a natural hormone which is produced by the pineal gland and released in response to light-dark cycles. It increases at night and decreases during the daylight hours. Adding melatonin to a person's medication regime at night assists in this rise, causing the patient to become less alert and drowsy. Overstimulation can disorient patients and cause or aggravate delirium. Strategies such as to ensure clocks and calendars are visible to patient, communicate slowly, simple and calm manner, playing light music can soothe extreme noise. Glasses and hearing aids are very helpful. Adequate light during the day and dimmed light at night to help with orientation and prevent confusion about time. And to keep safe. Always assess respiratory status and oxygenation, maintain hydration, evaluate presence of cardiac damage of CVA ischemia. Drug treatment is the very, very last resort. Try non-pharmacological management as much as possible. Haloperidol can help decrease agitation in patients with delirium because it works at the cerebral synapses and basal ganglia by blocking dopamine-mediated neurotransmission, facilitating stabilization of cerebral function. It is very important to be mindful of the environment of patient. Do not overstimulate. Must ensure good patient care and of course medications as hopefully the last resort. Non-pharmacological management, as mentioned earlier, is always the first step to management. The rule of delirium is to treat underlying predisposing and precipitating cause. Communication and behavioral management, environmental considerations. In treating the underlying predisposing and precipitating causes, treat all correctable contributing causes. Withdraw all drugs or taper when necessary, which are contributing to delirium whenever possible, or use the lowest possible dose. If infection is suspected, start antibiotics promptly. Ensure cardiovascular stability, adequate oxygenation, and electrolyte balance. Ensure hydration, monitor fluid intake and urinary output. Monitor elimination patterns, rule out fecal impaction or urinary retention. Assess and monitor nutrition and skin integrity, especially at the pressure sore areas. Identify and correct sensory deficits such as hearing aid or eyeglasses. Assess and manage pain using safest intervention. Support normal sleep patterns and avoid the routine use of sedatives such as benzodiazepines. Monitor the older person's physiological condition or mental status and evaluate response to care provided and modify as indicated. Delirium patients' comfort are very important because it also affects the recovery of their underlying cause of delirium. It is important to select high-risk medications contributing to delirium, and it is very important to know all types of medications from history taking as we assess delirium patient. And in management, we need to stop, taper down any unnecessary medication or any medication which is contributing to delirium. This includes the drug class of sedative, hypnotics, narcotics, drugs with anticholinergic effects, histamine 2 blocking agents, anticonvulsants, or anti-Parkinsonian medications. Second, in non-pharmacological intervention includes communication or behavioral management. To reduce patients' agitation, use behavioral management strategies to identify triggers and to modify the person's environment or delivery of care. Provide safety using the least restrictive measures. The use of restraints to control wandering or prevent falls is not justified. And we are talking about physical restraints. Encourage the presence of familiar faces such as family or friends, or consider a sitter to help calm and provide comfort to patient. Mobilize patient as appropriate. Consider the need for language interpreters if patient is unable to communicate in the primary team's language. Use clear and simple communication. Avoid confrontation and use distraction to minimize agitation. Provide the older person and family with ongoing information about delirium. Third is environmental considerations. Avoid unnecessary room transfers and have consistency in staffing. Use reorientation strategies such as clocks, calendars. Provide appropriate lighting to reduce misinterpretations and to promote sleep. Provide objects familiar to the older person to reduce disorientation. And ensure the environment is safe for the patient and for others. Pharmacological management of symptoms of delirium. These include the use of psychotropic medications to treat the symptoms of delirium should be reserved for patients in significant distress due to agitation or psychotic symptoms such as hallucinations or delusions, in order to carry out essential investigation or treatment, or to prevent older delirious persons from endangering themselves or others. Second, use of psychotropic. When using psychotropic medication, aim for monotherapy, the lowest effective dose, and tapering it as soon as possible. Antipsychotics are the treatment of choice. Haloperidol can be used, followed by atypical antipsychotics. Pharmacological management of symptoms of delirium. The use of psychotropic, using it as monotherapy. Haloperidol can be used, followed by atypical antipsychotic. Baseline and follow-up ECG recommended with antipsychotic. To monitor the QTC interval. For prolongation of QTC more than 450 milliseconds or 25% increase over baseline, consider cardiology consultation or discontinuation of the antipsychotic. Benzodiazepines can exacerbate delirium. Their use should be reserved for older persons with delirium caused by withdrawal from alcohol or sedative hypnotics. How can we prevent delirium? Potential interventions for the prevention of delirium include discontinuation of inappropriate medication, early detection and management of post-op or complication, early mobilization, early recognition of dehydration, ensuring adequate nutrition, health professional education on delirium and its prevention, minimizing the use of physical restraints, regulating bowel bladder function and avoiding indwelling catheters, reorientation or cognitive stimulating activities, use of sensory aids such as eyeglasses and hearing aids, ensure normal sleep patterns, taking a standardized approach to pain control, providing supplemental oxygen for hypoxia, and timely consultation for geriatric, medical, or mental health expertise. Interventions to prevent delirium, as mentioned earlier, here are some of it which we can practice and apply in elderly patients in the ward. Thank you for your time and attention. I hope you have understood about the topic of delirium and the importance of preventing and managing delirium promptly in the hospital wards to prevent mortality. I will see you in the assessment and also activities for the topic of delirium. Thank you and bye.